Okay. Hello, and thank you for joining the Policy and Legislation and Standards of Care webinar brought to you by the State and Community Intimate Partner Violence and Perinatal Depression Resource Development Project. My name is Keisha Highsmith from the Health Resources and Services Administration, Maternal and Child Health Bureau. Today's webinar is one of a series of webinars that HRSA MCHB and Social Solutions International, Inc. will be hosting to discuss select topic areas that are addressed in the newly developed resource toolkit entitled A Comprehensive Community-Based Approach to Addressing Intimate Partner Violence and Perinatal Depression. Next slide. Today's moderators for the webinar are myself. I'm the Director of Special Initiatives and Program Planning and Evaluation in the Division of Healthy Start and Perinatal Services within the Maternal and Child Health Bureau. We have Ms. Kristen Steer, who is a Research and Logistics Associate at Social Solutions International, Inc., and Ms. Gloria Ponte Clark, who is the Senior Policy Associate at El Tom Institute. Next slide. Today's guest speakers for the webinar are Dr. Jeanette Valentine, who is the Director of Business Development at Pathways LA, and Ms. Lisa L. Derrick, who is the Project Director from South Phoenix Healthy Start, Maricopa County Department of Health, and Ms. Kim Dartez, the Executive Director from Family Tree Health Care. Next slide. The objectives of the webinar is to provide examples of existing standards of care for IPV and perinatal depression, describe the process of implementing standards of care in your organization and the role policy and legislation play in addressing intimate partner violence and perinatal depression, but also provide examples of strategies, tactics used to advance policy and legislative initiatives concerning intimate partner violence and perinatal depression. Next slide. Excuse me. As I mentioned before, today's webinar is one of a series of webinars that will be discussing select topic areas from the resource toolkit entitled A Comprehensive Community-Based Approach to Addressing Intimate Partner Violence and Perinatal Depression. The goal of the toolkit is to provide a guide that is culturally and linguistically appropriate to support community-based programs, with making the case for why it's important to address the intersection of intimate partner and perinatal depression, and assist communities in reducing the stigma and provide strategies for building partnerships and increasing support from leadership. And to do this to ultimately improve the health and safety of families experiencing IPV and perinatal depression. So within the toolkit, we have different sections, and this section focuses mainly on policy and legislation. So the goal of this section within the toolkit is to provide an overview of the policy process and why it is important when addressing intimate partner violence and perinatal depression, and also highlight select federal and state policies related to IPV and perinatal depression. Next slide. So the goal of, again, we have another section within the toolkit for standards of care. And the goal of this section is to provide an overview of the importance of having standards of care for intimate partner violence and perinatal depression services, and also an overview of the national resources and IPV perinatal depression standards of care guidelines, and an overview of training materials and resources available to help address intimate partner violence and perinatal depression. So the toolkit is scheduled to be released this fall. So until then, we hope that you join us for the upcoming webinars and enjoy today's presentation. So at this time, I would like to turn it over to Gloria to introduce our guest speakers.
Hi, my name is Gloria Ponte Clark, and I have the pleasure of introducing Dr. Jeanette Valentine. Her background and training is in child development with over 20 years of experience in research and program development, and she's currently the Director of Business Development for Pathways LA, a community-based development agency. She also holds a faculty appointment at the Center for Health Services and Society at UCLA, where she collaborates specifically on studies of the impact of domestic violence and maternal depression on maternal child health and well-being. And you'll be hearing about her work with the steering committee of the LA County Perinatal Mental Health Task Force, and she participates also in the LA County Domestic Violence Council, an advisory body established by the LA County Board of Supervisors. So she has a wealth of experience, has authored many scientific publications and edited books, and I look forward to hearing her presentation. Thank you, Dr. Valentine.
Okay, well, thank you, Gloria, for that introduction. Welcome, everyone, to the webinar. And we could move through this if you'd like to go to the next slide, which would be our first slide. Although, before we go, I want to say the title to this is somewhat thematic. I came up with the title of Grassroots to Treetops. And the purpose of our slide presentation today is to really explore how local programs can impact policy and legislation on this important topic. So we could go to the next slide. Thank you. I did think about the learning objectives for today. I came up with a couple that are overarching. And I think the first one is I'm hoping to convey to our audience today ways that we can understand how local programs can have an impact at different levels of the policy-making process. There are multiple processes and multiple levels. And I think it's fair to say and important to note that when we think about how to impact policy-making, we're hoping to create some lasting changes that can improve the health and well-being of mothers and children that we work with. So key point, lasting changes, and that's why policy work is important. And I think it's important to think about multiple levels of policy, and we want to think about we have to work laterally or perhaps horizontally at our grassroots level, and we also have to work vertically. We have to think about how to influence those who are not within our local community but might be at the state or national level. I think the second goal of my presentation today is to help us all appreciate the breadth and the depth of the influence that local programs have. I think that becomes a challenge for many of us because we think we have a small number of families we might help. We are understaffed. We don't have the capability, the technical know-how around policy, and we certainly don't have the time to sit and have a cup of coffee with all the other agencies in our community. But actually, we have a lot of potential influence, and I hope I can share with you some of the thoughts of where you might pursue that leverage that you have. Okay, next. One of the thoughts I wanted to make sure we cover today is that there are probably, in my view, 3 key principles to having the capability and capacity and effectiveness to influence policy within, from the local level. And I think 3 of them come to mind. The first one is that we need to know who our audiences are. And I stress the plural here, that there are multiple audiences for policy change. There isn't just 1 or even 2, but there are multiple audiences, and we need to understand what they need to know, what they care about. While we know what we care about and we have information we want to share with them, in order to be effective or impactful, we have to know really what they need to know, and it has to be packaged in ways that they can make use of that information. The second thing is a key driving principle to create lasting change, in my view, is that we need to fully appreciate our power, the power that we do have, And sometimes we feel, perhaps, that we don't have the influence, or we're not effective, or we've tried these things and nothing seems to change. And that's particularly challenging around, I think, IPV intervention and so on. So, we want to fully appreciate the scope of the power that we really have. And then I think the third thing to effective, lasting policy change is to apply advocacy tools. And I again stress the plural here, that there are multiple tools. And sometimes we get locked into a particular set of activities that we've always done, or the easy on-ramp to influential individuals, and then we neglect or overlook or never develop the capacity to use the full toolbox, as it were, that really is available to us. So those are my three principles and the themes that I'm going to play out in the rest of the presentation. So next slide, please. Let's spend a little bit of time thinking about the issues around audience. And I put this together in perhaps 3 or 4 little groups here, but within each of these circles there's a lot of ideas here. But just to fully appreciate the different audiences, elected and appointed officials. I know we always, probably start there and think, oh, okay, we have to really focus on who, who's in the governor's office now, or who the mayor is, or, the president. And so we think about our elected officials that influence or that play a role in policy at state, local, and national levels. We also have appointed officials. Well, that's a little bit different, but those folks are really important. And do we have any ability to understand what role those folks play in decision-making and allocation of resources, and how we can actually reach those people to influence what they do? The other group I like to think about are thought leaders, opinion leaders. And we've heard that term. It's kind of interesting, different definitions of who those individuals might be. But actually, a lot of elected and appointed officials seek the counsel of thought leaders. So if we can influence the thought leaders and know who they are, who's on first kind of thing, they can certainly help us with getting our message across to other people who sign legislation and who write checks. So the third group I like to think about are business leaders. And we, in the nonprofit or public sector, we tend to have limited interactions or collaboration with business leaders. And sometimes we see them as, our adversaries, as it were. But actually, to be, again, creating lasting change, we really do need to think about reaching out to our business leaders. And on a very local level, there are local chambers of commerce. There's, of course, perhaps a large city one, for example, the LA Chamber of Commerce is quite significant and large and influential. But many of our little neighborhoods have community chambers. And those folks are really, really happy to help and support us in the community. So we need to reach out to the business community and incorporate them in our work. And then the fourth area is really what I call community leaders. And those are individuals that we work with a lot, probably. Some of the agency heads in our human service organizations and healthcare settings. And but all of those compose our audience. So let's go to the next slide then. Okay, let's think for a minute about the scope of the power that we might have. Let's start, first of all, with knowledge. Well, what do we know that we can actually share with policymakers? And to some extent, we say, well, we know from the ground what's happening, and we can share some information. But, if you don't have the data If you're not collecting data, you may not be able to package that. Well, and then so then you say, well, then I'm at a loss. Well, there are other forms of knowledge that we have that can play a significant role in informing and educating these individuals who influence resource allocation decisions and policies and practices at these various levels. So one form of knowledge, I think, is our experience in our program. If we can think strategically about developing some data for our clients and being able to present it in concise but impactful ways, I think is one form of knowledge. But we also have great power in hearing the voices of survivors, if you will, individuals who have had the personal experiences of IPV and or perinatal mood and anxiety disorders. So you've got your experiential base. And then you've got your evidence base, and there's a lot of evidence-based and best practices. So we can look at not only what we've done, but what others have done, and we can share that information to advocate or promote a particular position or view or request, for resources and so on. So there's a large scope of knowledge, but one of the things tying together the audience needs with the knowledge that we might have in our program is sometimes there's a disconnect. And that usually comes from the fact that we're not fully appreciating what our audience cares about. And we may have passion in the middle, which really speaks to our authentic caring about what happens to people, and that's very, very meaningful. But there has to be some way to put the information or knowledge in the hands of decision makers in ways that they can make good use of it. And there's something that they're interested in that we tend to overlook, and that is the information about the cost of the problems we're dealing with. We tend to overlook what does it cost. And there are two ways to think about it. One is, what is the cost of doing something that will have a good effect on people? And that seems to be, at least most of us start there. We always want to say, well, okay, we'll tell you what you should be, what we need to be doing. We know it works, but we're not quite sure what it costs. Well, if you go back to them and even say, well, if this is what it costs, that's one part of the equation. But the other one is, this is something that many, many of us overlook, even fancy policy analysts, is estimating and sharing that information with policymakers as to what is the cost of doing nothing. And that's an important thing they really would like to know, because many times that's the key point, which is what happens if I do nothing? Well, the cost to families and children is manifest somewhere else in the system. For example, in perhaps homelessness, right? Or perhaps, in the case of IPV, excess emergency room use, or the cost estimated with years of life lost, if due to perhaps suicide or whatever. So there are other ways to estimate costs, but the cost in the equation is some piece of information and knowledge that it would be nice to share, but we tend not to be able to. So I want to go to number 2 in our power, which is our passion, and we have some real commitment, which is can be very compelling to decision makers. And then the third one is access. We do have access to policymakers, but we tend to overlook or underutilize that power. So if you go to the next slide, we'll talk for a minute about the tools and tactics in the policy impact arena. And one is we know about informing and educating elected officials and decision makers and opinion leaders and so on. But the second one is to collaborate, to reach across the aisle, as they say, and think about really working together with individuals and partners that perhaps we may not feel that comfortable working with. The third tool and tactic is mobilize. Let's mobilize, and let's say we'll get a letter writing campaign going or an email campaign going around a particular moment in the state budgetary process or something. And I think a lot of us spend time in the first room, the inform and educate, and in the third room, the sort of the mobilization, and we get locked in. We think that advocacy is about that mobilization process, but it's actually all of these. And then the fourth one is really to lead, to take some active, proactive steps, to make some lasting change. So let's go to the next slide, and I've got a little bit of detail and some illustrations on these things. So let's want to go into some depth to explore the ideas. Now let's look at this multiple audiences in the policy process. A way to frame this is to think about, number one, define your community. You can either define it in terms of geography or in terms of demographics. And so think about that, and then we want to think about who has a stake in this geography, if it's geography, or in this demographic. Let's go to the next slide. And we think about the legislative and budgetary audience. Think about, for elected officials, geography counts, not only your geography. Like if you take a look at you have a small area, so small you maybe even need a magnifying glass to see it, right? But for example, state legislature or legislator who is making budgetary decisions or program design decisions and allocation decisions and so on, they're thinking about, well, the senator in your area and your perhaps assemblyman. In the state of California, we have assemblymen and senators. They do care about that local area, that tiny little area. So we need to think about that. But if, on the other hand, you're looking at impacting policy at the national level, then you're looking at your senators who represent the state as a whole, and they're going to care a little bit less about your particular area and a little bit more about the overall statewide impact. But your rep, your congressional rep, is going to be really concerned about the tiny little geographic. So we want to think about making a list, start making a list of all of the legislative officials who have a stake in the geography, who may have a stake in the demographic of where you are serving your community. So let's go to the next slide. And when thinking about elected and appointed officials, I thought I'd make a brief list just to think about who do we mean, who's encompassed in all of this. And, of course, we think right away, again, about legislative individuals, even thinking at a city level or a county level. You have a city council or a county council or a neighborhood council. That starting out, radiating out sort of laterally or horizontally, and then having some impact, thinking about where some of those individuals in these tiny areas actually sit on other bodies or structures that make decisions. So we have legislative bodies that we know about. Then we have committees. We want to think about the committees that drive important processes. And then the third one are administrative agency heads. And those are appointed individuals, but they have a lot of influence. And particularly in the case of PPD and IPV, if we think about the the state Medicaid, agencies that administer that program, those individuals actually play an important role in defining the benefit structures, the benefit plans, the range of reimbursement for range of services. So, for example, the screening, the importance of resources for screening for perinatal mood disorders. These individuals in Medicaid agencies, state Medicaid agencies, play a significant role, and they need to hear from us, and we tend not to put them on the top of our list. Special commission. So there may be a special commission. In the case of LA, we have a county-level commission on domestic violence that was established by our County Board of Supervisors, which has 5 elected representatives that administer really all of the programs for the county as a whole. And they set up a special commission on domestic violence. And 5 years ago, that commission in LA knew nothing about postpartum depression, nothing about the mental health sequelae of intimate partner violence. And I gave one of the first talks that they had ever heard, this is about 4 years ago now, on the mental health impact of IPV on women and the racial and socioeconomic disparities in those impacts. So informing, and thinking quite broadly that there are a lot of levels of influence, and that commission advises the 5 supervisors that run the county of LA. And then staffers, that's obviously very, very key. We cannot, it's very difficult to get to these elected officials directly, or even the appointed agency heads, or these special commissions, but they all have staff. So we want to start with our staffers. And then we have appointed officials. Is that at the bottom of this? Yeah. Then that we want to, I covered that already. But so thinking about strategically what levels at which we can actually influence and we should target to all of these levels. Okay, next slide. Civic leaders, and we talked a little bit about that, the community leaders, the thought leaders, and the business leaders. And all of those levels and groups have different entry points for us. And again, we should think about strategically reaching those, because many of those folks wind up sitting on these other bodies and then can take our message, to those that write checks or sign bills. Next slide, please. And let's spend a little time talking about the scope of our power. And what do we know? We do know something about the problem. We do know something about solutions. And I think I made the point earlier, we should know something about the costs. What does it cost if we don't do anything? And that it really does speak to some new information, and we may have to partner with others who can generate some cost data or projections of costs and thinking about what happens down the line if we don't do anything. And thinking broadly, the impact on women, the impact on families, the impact on children, the impact on actually the public sector, the costs. This is the kind of information that, while on the one hand, we do feel pain when people are suffering, but at the end of the day, most of these policymakers need to know how much it's going to cost to solve this and what's the downside risk if I don't do anything right now because I don't have any money, kind of thing. So we need to think about that. Okay, let's go to the next slide. Again, what are the sources of the knowledge that we can bring to bear? And I think one is that we can bring, the knowledge about the problem and some solutions. Experts have done these studies. There there's actually a growing body of evidence now, which didn't exist really even 5 years ago, about the interrelationship between IPV and perinatal mood disorders. That linkage we still need to make for the policymakers, and we need to share this information, and hopefully you folks will have access to the new information that is coming out from the experts. So we certainly want to share the knowledge that we might have, because no one's going to pay attention to it unless we bring it up, from the experts. And then we also have the experience that can speak, which is our personal stories. And we can build a group, many advocacy organizations do this, of survivors or individuals who've gone through these problems and have emerged successfully, and they can come and they can, with courage, share their stories. And those are very compelling to policymakers. And then wisdom speaks. Now, here's another thing. If you actually went into the literature today and tried to find evidence-based interventions on what works to address the combined problem of IPV and PPD, there's actually a blank space there. There's not much evidence base there for what would be a good thing to do. Short of that, we, as a community of providers, we have some perhaps license to define what works based on our experience working in these communities for a long time. And that's more than just personal stories, and it's certainly not going to be evidence-based. You're not going to provide randomized clinical trial results on what you've been doing. But we need to package this as community-defined evidence, and that's of great value. And this comes from the speaking from the heart, speaking from the grassroots level, and having a consensus in your community that is perhaps cross-cultural in nature and perhaps cross-sector in nature, but go for some type of consensus around trying to assemble a consensus within your particular community. It works in your community. We are not telling people that it's going to work in Idaho and it's going to work in Manhattan. You're saying it's going to work where you live. And there's an audience for that knowledge. Okay, so let's go to the next slide. As I was saying, there is a lot of power in the passion that we have. And, you know, we're the only ones that have it. And, of course, what we want to do is persuade others, you know, to see how important the problem is. We have some authenticity. We should speak with that voice. We have a sense of urgency. We have to speak with that voice. And this is the last one. This is optimistic here, but we have some actionable solutions. Because if we do go to policymakers and decision makers, they will be sympathetic. They're not going to share the passion that we have or the concern that we have, but they will certainly be sympathetic. But then they want to know, what can I do about it? So beyond our passion for the problem, we need to present them with some ideas that are actionable within the spheres that they have some control over. And that is such an important point. It's easily lost or overlooked because we actually don't have perhaps the analytic tools or even the analytic kind of thinking within programs that can get ourselves out of our day-to-day and think about these policymakers sitting in other offices in other parts of your state or community. What do they need to know? They actually want to know, well, what's actionable? And I think particularly challenging with IPV is that there's a lot of it's very challenging to have a good outcome. We know that, and particularly because of the interface between mental health and the experience of abusers and trauma. So we know that a lot of the conditions tend to be chronic, and so it's challenging to get over that, to say, well, what can we really do about this? And even some of us working right at the grassroots level, we shake our heads at the end of the day and say, man, I spent 6 months on this case, and look, whatever, it just went back to base. So we need to come up with some actionable solutions that are authentic and share that urgency. Let's go to the next slide then. Access. Do we have access? Sometimes we think we do. We overestimate, our power. Sometimes we underestimate. But in fact, we actually have quite a range of power through the access that we have to actually many individuals and groups that can help us. We actually have access to voters. I mean, we actually, if we advertised or did some social marketing, to voters about the problem, we could certainly let them know, what's important. We have access to civic leaders. We can call and set up appointments and go meet with them. We can send things out via social media or so on and so forth. Through electronic media and through the print media, we can access a lot of individuals that way. And we have access to clients and other community residents who might play a role in the policy making or policy influence process. Maybe they're not voters, maybe they are. But those constituents are there for us to actually reach out to. And then we have our agency partners and our collaborators. And there's a lot of influence there that we need to think about. And it may seem overwhelming, but they're very accessible and want to hear from us. So let's go to the next slide. So just to go a little more quickly through the tools and the tactics, we've got here inform and educate. There are a number of things that we can do to inform individuals who can make a difference. We can give testimony. We can give briefings in the form of written materials, or we go and we just talk to people and have that cup of coffee. The cost and outcome data that we need to generate, whether we've got it or we can look at some studies that have tried to estimate the cost and share that cost information. The survivor stories, the legislative, regulatory, policy kinds of models from other states or other communities, community news and media outlets. We can inform and educate using those tools. Next slide, please. So within the collaboration, we need to think about forming strategic partnerships, coalitions, and possibly task forces, ad hoc, or an existing task force that might be working on. In our case, for example, our task force is focused on perinatal mood and anxiety disorders. We don't have a focus on IPV. We don't even have a special sub-focus on IPV. It's all about that, perinatal mood disorders. But we can integrate and link IPV issues to that entity. Our Domestic Violence Council is all about domestic violence. They are not dealing specifically with IPV. We have, despite all the work that we've done so far in LA, we have yet to really link the Domestic Violence Council with the Perinatal Task Force, but we have to do that. So we think about collaborating. We can't do this alone. So let's go to the next slide. Another tool and tactic is the mobilization one, which is actually the most popular. Most people seem to be the most familiar with that. We form the partnerships. We form a coalition. We might actually partner with some organization. For example, we have the Community Clinic Association of LA, which is all of the federally qualified health centers in our area, they have pulled together several pieces of legislation that's focused on increasing maternal perinatal services for pregnant and postpartum women. And part of our issue is their issue. Part of their issue is our issue. So we come together, even though we don't work directly with the clinics on a day-to-day basis. So we form these coalitions, and we connect to these other groups. And we mobilize clients. That's a popular one, clients, community residents. And we tend to do it. I've seen it in my work here in child care services. We mobilize the child care providers and the parents every year. Guess when? When the budget is presented by the governor. So, you kind of go, well, okay, that's a big deal. But there's so many opportunities all during the rest of the year and at other levels of the policymaking process to influence the issues that come up at the budget stage. But we tend to just zero in on advocacy, policy, and we think that our role is, our strength is really in the client and mobilizing around a particular bill or something. And it is important, but it's only one small piece of the pie. Next slide, please. And the last one is to lead. I come up with a bullhorn little clip art here because it's very difficult to come up with a representation of what it means to lead, pictorial. But I think that speaks volumes right there to the significance of leadership. So we have to identify champions. We should take some initiative and draft the policy language, the legislation, the regulatory rule changes we might want in the Medicaid program or something. And then we develop the grassroots leadership. So there's a variety of things. So let's go now to the next slide. So I want to just spend a few minutes going really quickly now through this, just a couple of exhibits that illustrate the policy changes that we have had some success with in LA, and to let you know that in California, in case you don't know, we've been economically hit fairly hard and a variety of reasons. But our budget have been slashed for these vulnerable families. Nonetheless, when we had some successes. Even though no money has flowed, we've had some successes with the state legislature and the county level elected officials in recognizing and doing what they can do right now on the problem. So I wanted to share that with you. So if we could just quickly go to the maternalmentalhealthla.org website, just wanted to point that out to the viewers today. When you have a chance, you can go to this website and take a look at what we're all about. But I want to show you what we're doing on the advocacy level. And if you could just click on policy brief, that's number one. But I wanted to show you what we've got in this thing. We've done some short, these are one-pager little documents that we've used to inform and educate the elected officials and all these different people I've been talking to you about today. But okay, so that's there. We had a few of those, and then I want to show you the second one, which is reports. We started all this trouble back in '09, and we did we held a policy roundtable, convened all of these kinds of individuals that I've been talking to you about, and we just brainstormed and pulled together. We did a summit, and then we pulled together the information, and we packaged it, and we disseminated it through all of the media and methodologies that I went over today. Those are there, as illustrations. And then I wanted to show you the third one, which is legislation, and that's the one I pulled off for today's talk. And there are a variety of things here, the things that we've done. Well, to do something, as they say in the policy world, that's revenue neutral, it's coming to the state of California to ask for anything with your hand out today is just doomed to failure, as it were. But okay, so what did we do that was revenue neutral? So one of the things we did help to get established here, again with coalitions and partners, we succeeded in having a joint concurrent resolution, which is both houses of our legislative body, signed an agreement designating the month of May as Perinatal Depression Awareness Month every year. And that was a very big step for the state. Let's go to the next slide, please. And then this, we worked very hard on this and had another concurrent resolution. This is truly the illustration of the revenue neutral, but you know it certainly has gotten people to sit up and take notice and take some leadership around this issue in the state legislature. Urges hospital providers, mental health care providers, health plans, and insurers, that's a lot of appointed officials here in that laundry list, to invest resources to educate women about perinatal depression risk factors and their triggers. That doesn't say we want the doctors to screen, we want interventions to be provided, but it locates the problem. And this was, again, a concurrent resolution. Let's go to the next one. And then this is a third one I thought I'd like to share with you, which is at the local level. At the county level, we have not a county council, but as I was explaining, it's something called a board of supervisors, and it's 5 officials who represent 5 different sections of the 5 different geographies within the county. And we pulled together this proclamation, again, declaring May. So we have something going on at our local level, and we advocated it statewide, to have this done. So let's go to the next slide. This is a California Assembly Bill 159, the Healthy Mothers Act from '09. And this was modeled, I called this an illustration from national because there was a model done, there is a model nationally of the Healthy Mothers Act that has passed. Again, revenue neutral because nobody wants to put any money into this because we have not done our full job yet of explaining to these policymakers what does it cost to do something effective and to persuade them, explain to them, and if you don't do anything, it's going to cost you somewhere else, and it'll cost you even more. But in any case, we did get this going in the California legislature, to establish and convene a statewide task force to develop recommendations and educational materials for state departments of public health. This is a national bill, and we've been advocating this here, and we have established that here. So let's go to the last slide here. So I'm pretty much done, and I wanted to say something just about a few concluding thoughts for the Healthy Start programs and other local-based programs. That the time, everything I've talked about is time-consuming, requires some kind of talent or skill, and some resources to conduct policy work. They're very limited. We don't really have positions, But on the other hand, policy and systems change is embedded in our mission, and certainly from the very beginning of the Healthy Start program, well over, it must be a couple of decades now. So, we have that as part of our mission. So we have to find a way. The individuals at every level of the policymaking process want to hear from us. That we need to know in our heart of hearts. But the message has to be policy relevant, and when I say that, I mean everything about all the passionate things we know about, but also the dispassionate stuff about cost. And they have to be actionable. So give them something they can do. And I want to say something about those resolutions that we did here. If we had pushed for solutions that had price tags in this current budgetary environment, we would fail. So when I say actionable, I don't just mean sort of describing what to do, but I mean something that understands the dilemmas that the policymakers are in. yes, I'm sympathetic, but man, I can't write a check today. What can I do? Give them something they can do. So those are my closing thoughts. And I think that's about it. And I wanted to say that I'm leaving my contact information, for anybody who wants to learn a little bit more. But also wanted to say that there's a list of some additional resources that I would suggest, some websites and so on, which I could make available to the team at some point in the future. But this is a perspective that I was able to share with you from certainly from the LA County level here. So thank you. I think that's about it.
Great. Thank you so much, Dr. Valentine. I think the LA County experience really provides a lot of actionable examples, as you said, on what local and state communities can do to address intimate partner violence and perinatal depression. So thank you very much. And as Dr. Highsmith mentioned in the beginning, Social Solutions has worked with HRSA to develop a toolkit for community-based organizations to address intimate partner violence and perinatal depression, entitled A Comprehensive Approach for Community-Based Programs to Address the Intersection of Intimate Partner Violence and Perinatal Depression. I'm going to take just a few minutes to briefly discuss the components that are in this toolkit in the policy and legislative section. And as I mentioned, the presentation we just heard from Dr. Valentine highlights a few of the components that we list in our toolkit. So first of all, advocates for intimate partner violence and perinatal depression are knowledgeable about the needs of women and can really seek and shape IPV and PD policies. And so it's important to understand the process for creating policy and legislation so that you can address these issues at the local, state, or federal level. So the toolkit introduces the process for public policy making, which could be broadly summarized in the following steps. First, citizens are being heard. A concerned citizen group or legislators, several different audience members can have an idea and want to support legislation by suggesting specific policy items that can be addressed. And this is how individuals can really have a voice in shaping policy. And then, of course, you can write the bill or create the commission, as Dr. Valentine suggested. A legislator can write a bill and advocate for it, or your local community leaders can form a commission and start to think about types of policy initiatives. And then, of course, you formulate the policy, which requires a supportive political climate, and it also requires sound information about IPV and PD. And this is where advocates can really play key roles in providing their experiences or information or evidence-based information to policy and decision makers. This is where our advocate stories can really be helpful. Of course, we have to implement the policy, which is where the policy is actually enacted, regulations are written, money is appropriated, and enforcement procedures are put into place. And then after the implementation comes the policy evaluation. Policies usually include provisions to evaluate and determine the effectiveness of policy and legislative efforts. There are a couple of policies in place at the federal level that have impacted intimate partner violence and perinatal depression, and many people successfully came together to advocate for these federal policies. The first the toolkit highlights is the Violence Against Women Act of 1994, which has since been reauthorized several times. And the VAWA essentially funds services that include targeting, investigative, and prosecution of violent crimes against women, imposing automatic and mandatory restitution on those convicted, and allowing for civil redress in cases where prosecutors choose to leave the case unprosecuted. And most recently, the Affordable Care Act offers another example, which requires health insurers to include certain preventative health services free of copays. And this includes some depression screening and counseling. The toolkit also highlights several successful state policies and legislative efforts that have been implemented. There have been several, so this is just a brief overview. And in the case of New Jersey, there was a mandated screening for intimate partner violence, which is certainly a great step forward. And in Massachusetts, a commission was created to better address the postpartum depression programs in the state, which included several different items. The toolkit also provides information on the compendium of state statutes and policies on domestic violence in healthcare prepared by Futures Without Violence, which is a critical resource for any organization looking to understand the policies that are relevant to their specific state. And as Dr. Valentine mentioned, there's several different strategies that advocates can suggest in terms of making policy and legislative efforts successful. And these could include not only the mandated screening, but mandated reporting of intimate partner violence, home visiting programs, new parent programs, work groups or consortia, healthcare providers trainings, and general raising awareness campaigns. And finally, the toolkit provides a policy brainstorming tool to assist organizations in preparing for policy or legislative activities. And here's just a sample of some of the questions the toolkit provides, which really prompts organizations to consider what they need in order to be successful. So we prompt organizations to consider the key issues and challenges in your community, consider the stigma surrounding these issues, maybe take note of the actual rates of intimate partner violence and perinatal depression in your community, and think about the types of resources that are already available for screening, referral, and treatment. And then, of course, think about the types of policies that would actually be helpful to your organization, and what are some of the policy ideas that you have for addressing IPV and PD in your community. So as I mentioned, that's a very brief overview of this section of our toolkit. I will also be presenting in a few minutes on the standards of care section after we hear from our next presenters. They are going to discuss the standards of care and their experiences at the Phoenix Healthy Start. And I have the pleasure to introduce Lisa Derrick and Kim Garhez, who will be presenting on this topic. Lisa Derrick has worked as a program director for South Phoenix Healthy Start for nearly 10 years, and she has worked in the Maricopa Public Health Department and healthcare system for 25 years, previously as the director of clinical and non-clinical education, and managed the training department for the state's program in Arizona. Lisa also served for several years as the chair of professional education for the local chapter of Postpartum Support International, and is a founding member with Dr. Christina Hibbert of the Arizona Postpartum Wellness Coalition, dedicated to educating the professional and lay community on postpartum mood disorders and the impact of postpartum depression on families. And Kim Garhez is the executive director of Family Tree Healthcare. Family Tree Healthcare is a company whose guiding mission is to promote healthy families in communities of color. And Ms. Garhez has over 12 years of experience working in the fields of domestic violence leadership, advocacy, and education around providing quality services and support for underserved populations throughout the state of Arizona. Ms. Garhez also currently serves as the chair for the Women of Color Committee for Arizona Coalition Against Domestic Violence, and recently represented Arizona for the 2012 National Women of Color Leadership Summit in Minnesota. And with that, I will turn it over to Lisa and Kim.
Thank you for that introduction, Kristen. Appreciate that. It's really my honor to represent some of the fine, innovative, and proactive work that we've been doing here in our Healthy Start program. Next, please. Over the next few minutes, I'd like to take the opportunity to present to our colleagues our Healthy Start program's process, some tools, techniques around the way we've been able to integrate IPV screening and subsequent interventions into our current perinatal mood disorder screening and intervention process. And also take some time to present some of the work that we've been doing in engaging our community that can help us sustain and create a particular culture of support and intervention for the families experiencing IPV or perinatal mood disorders. Just a little bit of background. About 3 years ago, we began to recognize the truth behind that prevalence that we know of IPV and the co-occurrence with perinatal mood disorders. And through some of our own internal evaluation activities, we started to show a correlation between those two traumatic episodes within our families' lives, and indicated our data indicated that nearly 40% of our women enrolled in our Healthy Start program were currently or recently have experienced intimate partner violence as well as postpartum mood disorders. Next. So how did we start to look at some of the developing interventions? We needed to start with our screening tools. One of the 5 core services that all of our Healthy Start projects conduct is perinatal mood disorder screening or postpartum depression screening. And one of the tools most commonly used by many of the Healthy Start projects throughout our country is the Edinburgh Depression Scale. And we have been conducting this for nearly 10 years with our women. And so we didn't really need to do anything new with this. What we did have to do was find a screening tool that allowed us to assess domestic violence or intimate partner violence within our women, other than just what incidentally came up in conversation as we were screening for depression. So we wanted to also find a tool that could be used upon that initial intake and enrollment so that we could begin this dialogue around these particular critical needs. And we needed a tool that we felt that was evaluated as being valid and reliable, and particularly one that's valid and reliable with from a multicultural perspective and even gender population, where particular questions around intimate partner violence would be palatable, so to speak, for women of different cultures and certainly men and those in same-sex partnerships. And so we analyzed some best practices with some of the other Healthy Starts. We took a look at ACOG standards, and then certainly recommendations and evidence that were provided during several couple of years actually worth of DV-specific technical assistance conferences offered through our Healthy Start Leadership Institute. And so one of the tool that we found and we began using was the abuse assessment screen. And this was a screen that was being used. It's a series of 4, and sometimes we see 5 questions. It's often used in emergency rooms. We felt that because we were doing this upon initial intake and enrollment, it was important that we had reliable responses within that very short period of time, similar to what women would encounter in an emergency room setting. We also at that time felt that it was important to find a tool that would be literally able to be used by anyone. Our particular project employs mainly community health workers and are supported professionally and supervised professionally by an RN and a master's prepared social worker. And so, and we also really use a lot of community volunteers that come in and out of our program from time to time. And we felt that this tool needed to be available for anyone, whether it's an admin, staff, volunteer, or a staff member at any level. And so the adoption of the AAS screening tool in those 4 questions was a natural selection because it can be administered. And I outlined on this particular screen kind of the components of each of those screening tools and the results that we receive and then the subsequent actions. Next, please. We also knew that it was important to establish standards of care and service and actually get our own internal policy taken care of. And so this particular slide outlines some of those key components within our internal policy here within our South Phoenix Healthy Start. You can see that obviously we are screening all women. So regardless of whether they are prenatal, interconceptional, preconception, or coming in with an infant that's under the age of 2, they are being screened for both perinatal mood disorders and intimate partner violence upon that initial intake, and then with routine follow-up. If we get a yes response on our Edinburgh or our AAS, and there's an indicator there may be active IPV or perinatal depression, then we move into identifying this person as a high-risk case, which then indicates that our frequency of home visitation and contact is increased. And the standard that we feel meets the need is at least 4 contacts per month with our highest level of risk women. And at least one of those need to be face-to-face. We also believed that we needed to be able to have specific barriers identified in regards to the follow-through on any referrals that we are providing within the community or even within our own program, and that there's a very specific standard of documentation that is occurring within our own database and our own case management. And based upon those barriers, specific plans are developed that address the barrier, but also strategies to help overcome that, so that they are able to follow up with those referrals. But we also know that going to counseling or attending a support group within a community sometimes is a huge step for some of our women. And so one of the things that we established in our standard of care is that our women would be supported directly by our Healthy Start team in being able to attend that first visit or that first group setting. And we actually have dedicated resources in the areas of transportation and staffing that assure that they're able to get there. So we're able to actually drive them and attend that first counseling session, or we attend the first support group or transport them if needed to their first support group, so that they have someone there with them that can, one, assure that they get there, and two, that they feel supported during that first big step of getting assistance. We also have the standard that all of our staff within Healthy Start, and I put emphasis on all staff, even myself and any other management staff and administrative support staff are trained. And we continue to receive training throughout the year. I established a standard of around at least 12 hours per year on these particular topics. And we're conducting regular in-services and attend various workshops in the community throughout the year to satisfy those at least 12 hours. It's also important that we offer an opportunity for staff to be able to be debriefed on these critical incidents when they do occur within our population of program participants. And so as a part of our standards of care, within 2 working days of a critical incident involving one of our participants, any of the staff that are involved either directly or in some cases indirectly, and in cases of potential safety issues, all staff would be involved in a debriefing activity. This is our opportunity to conduct some reflective supervision, asking some reflective types of questions to allow people to share their feelings, but also to contribute to safety planning in some instances. Next slide, please. So here's a brief outline of some of the strategies and interventions that we have been able to incorporate to meet the needs of those standards of care and service. It's important for us to be able to have a network of crisis support, not only in the immediate need for mental health, but also in the area for shelter, housing, and even nursery respite for the children that are also either directly or indirectly being impacted by intimate partner violence and even postpartum mood disorders. Getting them out of the current situation in with an emergent need is very important, and so having those connections also is a main strategy in maintaining those connections for us to be successful in providing that first step of support for our women. The second is having access to medical care. The Center for Healthcare Against Domestic Violence that's located within Maricopa Medical Center here in Maricopa County in Phoenix, Arizona, actually provides not only educational support to their medical providers and interns and residents that come through their facility, but they actually operate a clinic there in which women can come 24/7 and be seen by a dedicated group of healthcare professionals that are trained in both IPV and perinatal mood disorders. And that treatment, there's a variety of different methods of payment. Medicaid certainly is one of them, but for those not eligible for Medicaid, there's a variety of different financial plans that are available on sliding scales and so on and so forth. So that access to medical care is extremely important. At the same time, so is some of the legal services that may or may not be resultant of the Intimate Partner Violence Act. If she's needing to leave or feels threatened and needs to secure orders of protection and those type of activities, then having a link to those legal services is very critical. It's interesting that the Center for Healthcare Against Domestic Violence has been empowered by the Maricopa County court system to actually provide right there within their clinic orders of protection. And they're able to secure a judge's signature on that order of protection immediately. And it's kind of a model for integrated services for women so that they don't have to make multiple stops and go to different places while they're actively experiencing the trauma related to IPV and even postpartum mood disorders. We've been able to secure through one of our projects, community health workers and her personal network, an opportunity to partner with a group of multiculturally competent therapists, PhDs, psychologists who are offering pro bono counseling to our women who need more intensive one-on-one or family therapy. And they use a cadre of PhD students from several colleges and universities and supervise them in the family therapy and individual therapy that they receive. We've also established peer-led support groups or non-therapeutic support groups that meet on a regular basis. We have teen-specific groups, adult-specific groups, and then language and culturally specific. Culturally specific groups, although we have not conducted one of those yet, we have a group of refugees from an African nation that is relocated here in the Phoenix area that has requested a specific group as well. And then various community-based support groups have been developed that allow for continued longer-term support that's able to meet the needs of the women closer to their particular neighborhood. The peer support groups and the funding for the facilitator training for these peer-led support groups has come from state funding through our First Things First Regional Council grants. So we've gone to outside sources for the few $1,000s that we pay per year for our facilitation training. Next slide, please. On this particular slide, this is just to show a few examples of the topics of training that we offer our Healthy Start team and the community. We feel that it's critically important that much of the baseline knowledge is consistent within the context of our community, and our main avenue for that has been through our community consortium and also through our outreach events within the community where we're able to do quick awareness and promotional types of education on these particular topics, and also promoting longer workshops and educational activities within the community that may be occurring. Under the staff training, again, these are typical topics that are offered to not only new employees coming in, but also existing employees. We continuously need to be updated in crisis intervention resources, so that's a topic that's offered a couple of times during the year. and then certainly any of the legal processes that are changing in the state of Arizona. One of the newest, and I think one of the most innovative offerings in training is for our staff is the infant mental health. We know and recognize how the trauma of living with a family that's experiencing intimate partner violence and even perinatal mood disorders impact our babies. And so it's important for us to be able to learn how it impacts, but more importantly, how we can begin to work with the families in overcoming some of those detrimental and potentially developmental developmental delays that can occur and emotional delays that can occur in infant mental health during this traumatic situation. I think one of the other areas that is very innovative for us, and again we're using funding from our state grants, is in the male support services. There's 3 particular focus areas for male support services. A lot of these are hopefully preventive-based, but they're also interventions as well. The Fathers Mentoring Fathers particularly is an opportunity where these men are sitting knee to knee with other men and really unloading a lot of the baggage that can actively contribute or potentially contribute to them committing intimate partner violence. And it also helps link them to individualized counseling services and other resources that can assist them during intervention of intimate partner violence. And then the other 2, providing them with tools and techniques that can start to decrease or potentially decrease some of the stressors that could impact their behaviors. Next slide, please. This is just an example of how we start to create and how we work to create a culture of support around this topic of intimate partner violence. This is a card that each of us wear. It's a front and back card that we wear on our badge. And this hopefully begins to be recognized within our community. It's a nice pastel purple color with the symbol of a butterfly or mariposa on it, indicating change. And it's offered through the Center for Healthcare Against Family Violence. And they provide these at no cost to us and to other community entities so that we begin to have a consistent message that we are a community of support. And every staff member within our project and many of the other agencies are wearing these. And it has important numbers, resource numbers, but more importantly, it also provides us with those 4 questions in both English and Spanish from the AAS, or the Abuse Assessment Screen. Next. Another tool we used and we developed, and I spoke earlier about this in our referral process, is when we get an affirmative on either the Edinburgh or the AAS on intimate partner violence, we have a tear-off card. And this is kind of like, I would say it's like a prescription pad, like if you go to the doctor and they write a prescription and they tear it off for you. This is a tear-off pad. And it's a tool that we developed that allows us to give that person immediately the date and time of the next Healthy Relationships, which is our support group that we offer, a referral to counseling, and certainly the emergency and immediate crisis numbers. But we tried to focus on her safety through a little bit of ambiguity if, for some reason, the alleged abuser would obtain this. We tried to keep it pretty neutral and not real heavy with a lot of information. No addresses or identifiers for our particular program were contained in there. Next. What I would like to do is turn this over to Kim D'Artes, and she's going to be taking the next few minutes to talk about specifically the peer-led support groups that she's been working with us on. Family Tree is the entity that we have contracted our state-funded through our state-funded grants to come in and do train the trainer or train the facilitator types of workshops, as well as conduct some of the initial or startup peer-led support groups. So, Kim?
Thank you, and thank you so much for this opportunity to share our program. A little bit of background. I've been the chairperson for the Women of Color for the Arizona Coalition Against Domestic Violence. Now, this is going on my 3rd year. And when I first began that work, even in the domestic violence advocacy field, there was a lot of confusion as far as the necessity for specific programming for women of color. The initial service model for DV was that DV occurs across all nationalities, all ethnic backgrounds, and so there was a little friction within the community as far as making specific services available to women of color and what was the necessity for that. Thanks to VAWA and some research, it's been recorded and proven that women of color do experience domestic violence in ways that are different than the mainstream. And so with that in mind, we began to look at how do we serve communities of color and overcome some of the barriers to our communities. We began to do that in the Women of Color specifically. And then I'm also a member of the Healthy Start Consortium. So working with Lisa and with Healthy Start, we began to look at all of these DV cases and look at how could we best serve these women in a way that would affect positive outcomes. And so one of the first things that we looked at in specifically serving African American women was our barriers to service. We have such a high distrust of the system, and most of our women were not even going to shelters, so they were like fallen within the cracks as far as being counted within the state. So we looked at all of that information to put together the support-led group. So this slide here, there's some of the outlines or guidelines that we came up with for topics for the meeting. So like the first meeting, we give everyone an opportunity to share who they are and to explain the Healthy Relationships program. And we talk a lot about confidentiality and safety. We also have a confidentiality form that we ask everyone in the group to sign to ensure that what's said in that group stays within that group. One of the next thing that we do is we give definitions, because a lot of times women do not identify themselves as victims, even though they may have been living in a domestic violence situation their whole life. As women of color, we have a lot of times been forced to be, quote unquote, the strong one. So the idea of identifying as a victim, which would be a weak person, is something that we reject. So when you're talking about victim services, and especially with these young ladies, a lot of times they're not even going to hear what you're saying. So we began to look at how could we define this and engage the young ladies to want to come. Another thing that we found was the health disparities, not only with the post disorder and obviously the early birth, but we looked at how our health is affected by the stressors of racism and by the stressors of oppression. And one of the things that we know in the DV community is that two of the most dangerous times in a woman's life are one when she's leaving a violent situation, and another is when she's pregnant. So working with the Healthy Start clientele and participants, these women automatically went into a high risk factor. So that's one of the things that we wanted to show. We wanted to show We want to show the young ladies how cortisol and the impact of stress on your life affects your health and affects even, when you're carrying the baby, and of course your mood and your depression and everything. So we take time to talk about that and to show that and to encourage the young ladies to make healthy choices, to make the choice to eliminate people from your life that cause you stress, that you can. Another thing we talk about is identifying internalized racism, and we define what that is. We talk about how it manifests in communities of color. We specifically talk about how internalized racism within, for example, the Native American community is really linked to the high incidences of suicide. And we talk about how internalized racism has even divided our specific and individual communities. We talk about how to identify it. We talk about how do we look at ourselves, how do we look at our partners, how do we look at our communities, and how do we look at other ethnicities? Have we developed racial stereotypes or ideas from a cultural perspective that are, number one, not true, and number two, unhealthy? So we look at that. The character counts, we look at, taking responsibility for your attitudes, your opinions, and the type of person you are. And then on the youth setting, we use that as a role-setting opportunity and help the young ladies navigate, through different scenarios, how to make a positive choice or how to de-escalate an incident. We also help them do goal setting. So every week when we meet, we have a small goal. So throughout the course of the support facilitation, the young ladies have made small goals and they've accomplished those goals. And as we go on, they choose larger goals. So we encourage and help them to realize, take back the power and control of your life, because domestic violence is really about power and control. So the more tools that we can give them to empower them, the stronger they become. Next. These slides are basic general guidelines on how to host a peer-led support group. One of the things that we found that I was really excited and ecstatic about was some of the outcomes. I mean, we've seen these young ladies in a matter of a few months decide to make choices that are not only healthier for them, but even wiser. I mean, we've seen young ladies leave abusive situations. We've seen some of them decide that, this partner is not for them. We've also seen some that have taken advantage of some of the tools that we share and actually come back and say, I was the abusive one in this situation, and I'm using, these communication tools to talk with my partner. We're talking better. We're getting along better. We're establishing boundaries. Some of the abuse that we've seen has been not even necessarily with the partner, but it may be parent to child, because some of the young ladies are still underage and living at home. So we've had a couple of cases of that. So anyway, I'll get back to the, sorry, I'm rabbit trailing off. But the steps to get your group started, I'll just go over them pretty briefly. The first thing was to decide the frequency of the meetings. Make sure what you start, you can finish. We always say try to keep your meetings to a maximum of 8 participants, because you want to allow everyone to be able to participate and share and have it manageable. We definitely recommend, if you do have 8 participants, try to have another facilitator with you in case someone needs one-on-one assistance. We always want to remind ourselves that we are not therapists. This is a community support group. It's community-led. So if we find that something that was said triggers someone, or someone has an emotional breakdown or something, we do have therapists that we can recommend them to. We have pro bono therapists as well. We also have trauma therapists. We try to limit the group to 90 minutes, but it's a pretty intense 90 minutes. But, you know, we don't want to open a can of worms and then can't close it. But we try to keep the meetings fluid and manageable. We try to also conduct the groups in a cycle of 10, and we reserve the 9th one for anything that throughout your other group that you might need to readdress, or something that's specific to your group, because we want to stress they're organic groups and they need to be led by that community. So maybe a need in one community may not be the same need in another. So we want to keep it open and fluid to the members. Next slide. Okay, let's see. If, and we've run into this as well, at the end of the 10 weeks, some of the participants still want to continue with that group. That's really, I'm sorry? Oh. You can design your group to either allow for the same participant or start your groups again, restart them. One of the things that is not on here that I do want to share is it's really advantageous to divide the groups to young adults and adults. They have different dynamics, different needs. They'll have different questions. So if you mix up the ages, it doesn't flow as well. It's easier to keep everyone as close as you can to their peers. Secure the location. Well, we're speaking with Healthy Start, so you all have your locations. But this peer-led support group can be used anywhere in the community. We've used it in churches. We've used it in community organizations. We've used support groups held at the library, at the museum. So this is just an outline or a model. But if you do secure a location, you want to make sure that it's neutral, non-threatening. You want to make sure that the owners and or the management of that location understands exactly what your support group is, and you want to get them to sign a confidentiality paper as well. And then lastly, think of innovative ways to get participation. Some people will come just by word of mouth. Some will come through advertising, social media, Facebook. We also get recommendations from schools, and we also want to share the ways that we've been able to engage the community. So we always ask to be sure to share your recruitment. Next, please. And then some of the tools that we use as a group are the DV Power and Control Wheel, the multicultural perspective. That's where we really look at some of the internalized racism norms, and we go through them by ethnicities, and we kind of talk about it. That's where we allow people to share their own personal experiences and stories. The confidentiality, we have a basic form that we use, and it's modeled after the VAWA Act confidentiality, as well as the safety plan. It's modeled after the VAWA safety plan, the national one. The communication and facilitation skills is where we talk with whoever's going to lead that, continue to lead that specific group. We give them tools and keys on facilitating the group as they lead them. And meeting structure and navigating the meetings, those are also tools to help the facilitator to direct the meeting, not necessarily take the meeting over, but to keep it in structure and to navigate it. Developing a plan, that's going to be specific to the group that you're speaking to, whether it's a safety plan, whether it's a goal-setting plan. And then lastly, the contingency planning and resources. That's where we share the community resources available here in Arizona, and also, depending on the specifics of the case, the contingency plan for that. We've had some cases where the young lady was actually, her abuser was with the Mexican cartel, and this young lady still lived at home with her parents and had not disclosed the violence that she was dealing with this young man. I mean, it had gotten to the point he'd actually pointed a gun to her head, but she didn't want to share this with her parents for fear that her father would say something to them, for fear for her father's safety. So we literally had to make a total contingency plan for her and then for the family, as well. So that's a big tool too. I hope I didn't rush through everything too quickly. And again, thank you.
Lastly, I think one of the big points that I would like to get across is that it can't just be done within the confines of our Healthy Start programs. We really have got to get our communities involved in this, and we certainly heard Dr. Valentine talk about it from a policy level, but even more so. When we are doing this work, and we're doing this work within the community, we've got to have more facilitators out there, more individuals within our community that are willing to be trained as facilitators and to begin to host additional peer-led support groups. Those groups can be, as Kim said, offered within businesses, within civic organizations, and faith-based groups, to where there's ongoing places of support where our women and those affected by intimate partner violence and those affected by perinatal mood disorders can go and start to feel nurtured and comforted and well. And certainly her wellness translates into wellness of the entire family. One of the other areas for community involvement is participation in the annual conference that the Women of Color group conducts each year. It's a 2-day conference, and it's very accessible for the community, and it's a wonderful platform for them to be able to come in and really start to find out ways that they can become involved and be engaged in this, and find local resources that when the woman from their business or the woman from that she sits next to in church starts to disclose some of the challenges that she's having, she's able to readily provide local resources, whether it's to a crisis hotline or warm line for perinatal mood disorders, or whether it is for a shelter service, or whether it is for a local support group. All of that information is available during these conferences, as well as the resource materials as a result of it, so that we can provide consistent messaging and resources from a community-based entity. Next. Some of the lessons that we've learned through this process over the past couple of years is that it's so important, again, that we create a culture of support and trust. Women know that they can come to us. Individuals know that they can rely not only on Healthy Start, but our surrounding communities to support them through this really traumatic time. That we work with entire families. It's not just the woman who's experiencing this because of her chemical changes due to perinatal mood disorders or the intimate partner violence that she experienced. It's impacting those babies. It's impacting the other family members that are living within the home. We certainly have lots of families within Healthy Start that have multi-generations and families living under one roof, and everyone is impacted, and we need to be able to provide that support for them as well. And certainly self-care. As a provider, as someone that works with women experiencing the trauma of intimate partner violence and perinatal mood disorders, the co-occurrence of both of those, it can be very traumatic on us as well. And so having resources for our staff and our community providers is very important, so that we're well, so that we can help women and families achieve wellness. And we've both included, Kim and I have included contact information, so we both are very open to talk to our colleagues throughout the nation about our experiences more candidly and in more detail. Thank you so much for this opportunity.
Thank you so much, Lisa and Kim. I'm just incredibly impressed with the array of integrative services that the South Phoenix Healthy Start has, and I think it just represents a really great model for other community-based organizations attempting to integrate both of these issues. If everyone will just bear with me for a few moments, I'm going to briefly go through the section on standards of care that we have in the toolkit, and then we'll take a few minutes for question and answer sessions. So first of all, the toolkit discusses that there are several standards of care guidelines for both intimate partner violence and perinatal depression, but there are a few that address the intersection of these comorbidities. And as Lisa pointed out, they integrated two different tools for their screening, and I assume part of that is because there aren't a whole lot of screening tools out there currently that actually integrate both of these issues. But what the toolkit does is provide a list, a non-exhaustive list, of several resources that organizations can use and adapt that are based on national guidelines and also include training materials, sample dialogues, and even sample screening questions. So first, the toolkit discusses why screening is important. And many studies have found that a majority of women, here we've listed 80%, are comfortable with the depression screening process, and 90% of women are comfortable with intimate partner violence screening process. However, less than 50% of women are screened for perinatal depression. Of those, 22% of providers were using validated screening tools, and only 10% of women reported being screened for intimate partner violence by their OBGYN. So what these studies suggest is that we not only need to be screening more, but we need to continue to share validated resources for screening, for referrals, and for standards of care. The toolkit lists several screening tools specifically for intimate partner violence. Here we just mentioned the Women of Youth Screening Tool, which is an 8-item instrument that measures physical, sexual, and emotional abuse in the last 12 months, and the Composite Abuse Scale, which is a 30-item instrument and measures overall exposure to violence. And then the toolkit also suggests resources that provide standards of care, such as the ACOG Committee Opinion on Intimate Partner Violence, which explains what IPV is and provides several recommendations, suggestions, and even sample questions for IPV screening. And it's important to point out that ACOG defines intimate partner violence as a pattern of assaultive behavior and coercive behavior that may include physical injury, psychological abuse, sexual assault, progressive isolation, stalking, deprivation, intimidation, and reproductive coercion. And these types of behavior are perpetrated by someone who is, was, or wishes to be involved in an intimate relationship with an adult or adolescent. And the toolkit is aligned with ACOG's definition of intimate partner violence as well as its recommendations and guidelines. And two of those I've listed here, the standards of care that ACOG recommends, is to use a framing statement and show that the screening is done universally, not because intimate partner violence is suspected. And I know that the South Phoenix Healthy Start did something similar for the referral cards that their employees wore. It's important not to have clients feel like they're being targeted. And it's also important to disclose issues of confidentiality and let clients know exactly what state mandates exist in terms of disclosing violent situations. There are several other standards of care that we include in the toolkit as well, so this is not an exhaustive list by any means. Some of the other resources that I mentioned were the ACOG Committee Opinion on Intimate Partner Violence and Perinatal Depression. We also mentioned Futures Without Violence, which has a lot of educational materials and IPV assessment and safety assessment tools. And we also include information on the National Resource Center on Domestic Violence, which has grants and funding information, and also provides technical assistance and training. So to briefly highlight a few of the perinatal depression screening tools, as Lisa mentioned, the Edinburgh Postnatal Depression Scale is one of the most commonly used for postpartum screening. And then some of the standards of care that the toolkit highlights come from the National Association of Perinatal Social Workers. They have 10 standards of care for social workers or other staff that are working with women to use when assessing perinatal depression. And here we just include that a standard of care would be to provide resources and referrals for women that are culturally and linguistically appropriate, as well as evidence-based. And it's also important to provide partners and family members with information about the signs and symptoms of perinatal depression to assist women with accessing those services. And some of the other resources for perinatal depression that the toolkit highlights is the Commonwealth Fund, which has information on when and who to screen, how to choose a screening tool, and how to establish a triage and referral mechanism within your office, as well as train your staff. The U.S. Preventive Task Force includes a lot of information on screening adults and pregnant and postpartum women for depression. And the American Academy of Pediatrics, in collaboration with ACOG, has guidelines for perinatal care that discusses how OBGYNs and pediatricians can work together to screen for maternal depression before, during, and after pregnancy. And finally, the toolkit highlights 2 tools that do integrate intimate partner violence and perinatal depression together. These 2 we have listed here. We provide much more in-depth information in the toolkit on them. And then we have a chart which includes access information for several of the screening tools and just a little bit more detail on each of the tools to assist you in learning about the types of screenings you might want to integrate in your own organization. So that is all we have for the presentations today. If you'd like to contact Social Solutions, here's my contact information. And of course, if you have questions or comments about the State and Community Intimate Partner Violence and Perinatal Depression Resource Development Project, please contact Dr. Keisha Highsmith.
Thank you, Dr. Valentine.
Okay, you're welcome. Bye-bye.
Bye-bye.
Bye.